Welcome to today's lecture on Poxoviridae and Parvoviridae viruses. So I'll start first by talking about Poxoviridae. This is a beautiful electron microscope image of these viruses. As you can see, they have nearly oval or brick-shaped morphology, and inside you can see very nicely the nucleocapsid. Okay, it looks like a dumbbell. The Poxoviridae is a family of viruses that's divided into two subfamilies and six genera. Species within each genus are closely related. The genus Orthopoxvirus causes human diseases. Okay, uh, this includes variola, the variola agent, which is smallpox virus. It also includes vaccinia, cowpox, and monkeypox. Okay, so the vaccinia is also used in vaccinology. So it's used as a vector to develop vaccines. We now talk about the properties of viruses. These are relatively large viruses. They are 200 to 300 nanometer in size, so they are considered among the largest animal viruses. They're pretty much comparable to some of the smallest bacteria like chlamydia and can be almost seen under the light microscope. Their morphology, as we mentioned earlier, is oval to brick shaped. They have an envelope, as you can see here in this elucidation, and here under the electron microscope, you can also see the oval or brick shaped morphology. And they have a DNA genome. Their genome is relatively big. It can be more than 18 kb, for example, for vaccinia virus. The genome is a single linear double-stranded DNA, right? So this is a DNA virus, and the replication is in the cytoplasm. Now this is unique, right? Because usually DNA viruses replicate in the nucleus, and I'll let you think about this for some time, and we will discuss it a little bit later. So the nucleocapsid of this virus has a rather unique morphology. It's complex. It is neither icosahedral nor helical, right? So it has a brick shape or dumbbell shape like morphology. Uh, it has a biconcave core. Here's a question. What does a DNA virus need to carry in order to replicate in the cytoplasm? Please think about it for a few seconds and then we can discuss. Okay, did you guess by now? So again, this is a DNA virus. Our DNA viruses usually replicate in the nucleus, so they can rely on the host cell DNA-dependent RNA polymerase. Okay, but in the case of Poxviridae viruses, they can replicate in the cytoplasm, but to do so, there is no host enzyme in the cytoplasm to help them replicate. So they need to carry in with them the DNA-dependent RNA polymerase. Next, we'll talk about the variola virus or the smallpox. Now, this is an eradicated virus, as we'll learn later, but it's very important to learn about it because there are so many lessons that we can learn from. Smallpox. So there are two types of smallpox. We have the variola major or the classical smallpox with a very high case fatality rate. The case fatality rate by the variola major or the classical smallpox reaches up to 50%, whereas the variola minor, also known as the Alström, is a milder disease with a case fatality rate that's less than 1%. And by case fatality rate means that the percentage of those die out of those who are confirmed to be infected. Okay, so the denominator is that those who are confirmed to be infected. Now, in the 18th century, the smallpox accounted for 7 to 12% of child fatalities. That is a huge burden, okay? But thankfully, the virus is now eradicated, and only a few labs in the world have this virus in their freezers just in case they needed to make new vaccines from it. So the transmission, this is a highly contagious virus. That means it is capable of very spontaneous and rapid transmission. It spreads primarily by the respiratory route, and we'll see that the inoculation happens in the respiratory route, and less efficiently through close contact with dry virus on the clothes or other materials. That means fomites. Okay, there is no animal reservoir for the smallpox, and there is no carrier stage. The incubation period on average is 12 days, ranging between 5 to 17 days. Now, I don't want you to memorize the exact number of days for the smallpox, but you just have to kind of differentiate between viruses that have very short duration, that have very short incubation period, like influenza and other respiratory viruses, which can be few days, and those that require a longer incubation period. And we'll see why it requires longer incubation period, because the life cycle is a little bit long. The pathogenesis of smallpox starts with the inhalation of the virus in the respiratory droplets. Remember, this is a virus that spreads via the respiratory route. So this is followed by mucosal replication of the virus and spread to the regional lymph nodes. That results in a transient viremia. So this viremia is short-lived, but it allows the dissemination of the virus to other organs and the skin, where the virus now replicates and produces large amounts. Okay, that is followed by a secondary viremia, which is much more intense and results in the appearance of symptoms. Now, this period here, the incubation phase, takes around 1 to 2 weeks. Following that, we have a toxemic phase. Replication of the virus in the skin epithelia results in a rash that is associated with development of focal lesions. The patients would have high fever and myalgia or muscle pain. Now, the rash starts as centrifugal, so it starts in the head and then it spreads to the arms, hands, and legs and trunk. So what are the symptoms of smallpox? So as we mentioned, the rash lasts for 3 to 4 days. The whole symptoms can last up to 7 days, and these include high fever, fatigue, severe headaches, backache, malaise, feeling tired. This is usually accompanied or followed by by vesicular rash. So the rash starts as macules, then they change into papules, and these papules become vesicles, and then they are filled with pus and called pustules. Okay. Now these can be very aggressive skin lesions that result in the appearance of permanent pock marks. Okay, we call these pock marks, particularly on the face. This results in a very debilitating state and is associated with really bad emotional feeling in the patients at the time. Now, also vomiting, diarrhea, and excessive bleeding would quickly follow in, particularly in patients who deteriorate. Okay, the severe focal lesions, particularly in the limbs and the face, can result in blindness or limb deformation. Okay, and in 1 in 10 people, it could result in death. Remember, there are 2 types of variola, the variola major and the variola minor. The major is the one that results in highest mortality. Now, it's important when we talk about the smallpox to differentiate it from the chickenpox. So the smallpox is eradicated, while the chickenpox, which is Jidr is not eradicated yet. The simultaneous outbreak of the vesicular rash is the one that distinguishes smallpox from the vesicles of the chickenpox or varicella zoster. Okay, so in the smallpox, the rash appears simultaneously. Okay, we call it synchronous. Okay, so they are synchronized throughout the body. So you'll find these rash at the same stage. While in the chickenpox, the rash is asynchronous. So you'll find different stages of the rash at a certain time. Now, if you also look at the distribution of rash on the body, Smallpox is centrifugal. It means that the rash spreads from the trunk to the extremities. You see more rash on the extremities and the head. While in chickenpox, it's called centripetal. So it's central, mainly concentrated in the trunk and the face. Of course, you can see some rash on the limbs as well, but it's mainly centripetal for chickenpox and centrifugal for the smallpox. Now, let's see. Why do you think it was possible to eradicate smallpox? Why we were able to successfully eradicate smallpox? Read the answers and think about it for some time, then we can discuss. So it wasn't because of the World War II that the outbreak or the disease spread ended. Remember that we don't have a known animal reservoir, so this is not the right answer. It's true that a vaccine became available, but just having a vaccine is not enough to eradicate disease. What do we need to have? We need to have herd immunity, and the only way to achieve herd immunity is to do massive vaccinations. So massive vaccinations were possible at the time, and this helped in successfully eradicating smallpox. So where did the concept of vaccination for smallpox and then eradication started from? So there was an English physician and scientist called Edward Jenner in the late 17th century, and he was a keen observer. So he noticed that the ladies that milk the cows, they develop sometimes lesions in their hands due to the infection with the cowpox. Okay, this is a virus that's similar to the smallpox, but it affects cattle. He heard the dairy maid saying that I shall never have smallpox, for I have had cowpox. I shall never have an ugly pockmarked face. There was a very strong stigma associated with these very bad lesions that occur in the face after smallpox infection. So from here, he developed the concept of variolation. Okay, this is a very early form of vaccination. So what did he do? Edward Jenner found a young dairy maid called Sarah Nelms, and as you can see here in this illustration, and he took a sample or collected some of the pus in her cowpox lesions that were in her hands and palms, and these would contain the cowpox virus he hypothesized. And then he used those to inoculate an 8-year-old boy in his arm. The boy was called James Phipps. Now, the boy developed mild fever and discomfort in the axilla, but 9 days after the procedure, he felt cold and had lost his appetite, and then he was feeling much better. So, another time, or a few weeks later, Jenner decided to inoculate the boy again. This is very dangerous practice, but again, that was how science being done at the time. This was a clinical trial being done by Edward Jenner, and this time he infected the boy, or inoculated the boy, with a fresh smallpox lesion. Okay, so he tried to infect him with a smallpox agent, and luckily the child did not develop any disease, and Jenner concluded that protection was complete. All right, so again, this was the basis for the concept of vaccination for smallpox. Now, variolation was slightly dangerous because it resulted in a case fatality rate or fatality in 1% of the inoculated children. So it was a dangerous practice, but it was still better than the risk of smallpox infection. So of course, the vaccine was then further developed to become safer, and massive vaccination campaigns were launched. So here we go. So why was it possible to eradicate smallpox? What was really so different that we could eradicate it? So first of all, the virus characteristics were very important. First of all, if you remember, there is no animal reservoir, so human is the only host, and there is a single serotype there, so there is not much diversity. Remember, this is DNA virus; it doesn't diversify as much as RNA viruses. So the availability or the fact that there was only a single serotype helped in making a vaccine that would be very effective. So the strategy was called, or the campaign, Smallpox Target Zero. Okay, and if you could see here, there was big celebration around the world when they eradicated smallpox. But among the other properties that helped eradicating the virus were the disease characteristics. So it was very easy to identify the infected people and isolate them. Okay, uh, so those who are infected, they have this really clear rash, and this is when they are infectious, and thus it was possible to quickly isolate these people, preventing them from further infecting others. Also, the vaccine was effective within 5 days of acquiring the infection. So even if somebody was exposed to the disease, then if they get vaccinated, they will be protected and they will not develop these pockmarks. Now, the vaccine itself was a bit easy to administer. It is stable and was inexpensive. Okay, and this made it easier to launch these massive campaigns and administer it, particularly in remote areas. The immunization with animal pox virus was found to protect from smallpox, so it was easy to have a safe vaccine in humans, and the presence of a scar indicated successful vaccination. So it was again easy to identify who has been vaccinated and who has not been vaccinated yet and then would be vaccinated. Finally, the Public Health Service. So the World Health Organization was successful in launching a massive vaccination campaign that was associated or accompanied by quarantine policies. So again, identifying infected people and quarantining them so that they don't spread the infection. So altogether, these formed a very good environment to eradicate smallpox. So the world could celebrate smallpox eradication, and this is now a historical. This was a historical moment. So we'll talk about some other pox viruses. So the second virus that belongs to the Poxoviridae family that I'm going to talk about is the Molossi pox virus, or the Molossus contagiosum virus that causes Molossus contagiosum. This virus is very common. It affects around 3 to 20% of the population, particularly in children, and it is transmitted from one person to another via physical contact, particularly sexual activity, sharing towels contaminated with the virus, and also getting in contact with contaminated surfaces that have fomites of the virus. And there's also the risk of auto-inoculation from one part of the body to another. For example, if somebody scratches the lesions on their face and then scratches another part of the body, then that could result in auto-inoculation. Now here you can see this lady here with these wart-like rash. Okay, they have wart-like lesions that are different from the vesicular lesions of the smallpox. These lesions are usually 3 to 5 millimeter in diameter. They have a pear-like appearance. Okay, and there is a dimple in the center of the bump. Now, once these bumps or lesions are gone, then the virus is no longer there. And also, this is important to know that unlike smallpox, in which we have a viremic stage, there is no viremic stage in this with this viral infection. The incubation period can be rather long, ranging from 2 weeks to 6 months. Again, I don't want you to memorize these, but just remember that it's longer than, for example, gastrointestinal viruses or respiratory viruses. The reservoir is only humans. And so we don't have an animal reserve. Now, the molluscum contagiosum lesions can be classified in one of three ways. The common ones are the ones seen in the or on the skin. Okay, these skin lesions that we can see on the face or the trunk and limbs of children. We have the sexually transmitted lesions that are found on the abdomen and the inner thighs of the genitals. Okay, and this is of course can be found in sexually active adults. And then we have those that are diffuse eruptions in the patients with immune suppressive disorders, or also those who are infected with the HIV or the AIDS patients. So here again, I'm showing you the symptoms of molluscum contagiosum. You see here this typical rash. So they look like wart-like pearl in shape, and with a bump that have a dimple in the center. Okay, so the rash begins with small papules, just like with smallpox, but instead of becoming vesicles, they grow gradually into waxy smooth pearl-like nodules. Okay, now the symptoms can take very long time to resolve, up to 4 years. Okay, here we're seeing a very severe case of molluscum in an immune compromised patient. Here we're seeing the back of the patient. Okay, so it can be tough in patients who are immune compromised. Now, what is the treatment for molluscum contagiosum, these wart-like lesions? So the treatment can be physical, like using laser or cryotherapy or curettage. Okay, just like we treat some of the warts, skin warts. Or we can use topical creams like the podophylotoxin cream 0.5%. This is not recommended in pregnant women because of the associated cytotoxicity. And also other therapies could include iodine and sialic acid. Now, orally we can give cimetidine, which is preferred in pediatric patients. This drug is thought to have immunomodulatory effects by blocking histamine-induced stimulation of T suppressor cell activity, okay, and enhancing the T cell immunity. Okay, so cimetidine has immunomodulatory effects that help alleviating the symptoms of the disease. So next we'll talk about parvoviruses. Parvoviridae includes two subfamilies, the Parvoviridae and the Densoviridae. The Parvoviridae family or subfamily includes two human viruses. The first is the human parvovirus B19 that belongs to the genus Erythrovirus, and the other one is the human bocavirus that belongs to the bovavirus. So we'll talk about the parvovirus B19 in a little bit. But I'll just give you a briefing about the human bocavirus. This is a virus that was thought to be first associated with diarrhea because it was found in stools, and then also was identified in patients with respiratory symptoms. But its etiologic role remained controversial because it was also present in high incidence in asymptomatic people. And then we have also the genus Dependovirus. From the name, these viruses depend on other viruses to replicate. So we have the adeno-associated viruses. These more or less rely on the presence of a helper virus, usually an adenovirus, to replicate. Now, the virus in this group, the adeno-associated virus, it doesn't cause illness or modify infection by the helper virus, the adenovirus. And these properties and their propensity to integrate into the host chromosome, made them a nice tool to develop genetically modified adeno-associated virus candidates that can be used in gene replacement therapy. So what are the properties of the parvoviruses or viruses belonging to the Parvoviridae family? These are actually the smallest DNA viruses. Their size ranges between 18 to 26 nanometer. Of course, I don't expect you to memorize these, but just kind of give you an overview of the properties of these viruses. This is in contrast to the large size, very large size of the pox viruses. They have no envelope. Their genome is single-stranded linear DNA genome. Okay, and as DNA genomes, they follow the usual route for replication in the nucleus. So as I promised, we'll talk about the human parvovirus B19. So why was it called B19? So the name comes from the isolation history. It was found in the blood of an asymptomatic blood donor that was coded at the time 19. Okay, so this is where the name B19 comes from. The B19 infection is known as erythema infectiosum. Okay, erythema infectiosum. The virus has a wide worldwide distribution. It affects around 65% of the population. So by 40 years of age, almost most of us would have had this infection. Uh, the only known reservoir are humans. We don't know of an animal reservoir. The virus transmits via respiratory droplets, blood, and transplacental routes. Now, the incubation period is 4 to 20 days. Okay, so the incubation period is 4 to 20 days. So a little bit of a wide range here. Again, no need to memorize these, and this is how this virus looks under the microscope. Remember, this is a very small virus. So what is erythema infectiosum? This is also called the fifth disease, okay, or the slap cheek syndrome. This is a very nice name because it really helps you memorize the symptoms. Look how this baby looks like, and this one here. They look like as if they have been slapped on the face. They have this really strong erythema. Okay, now this could be more severe in certain patients. Now it's called the fifth disease. Why? Because we have 6 childhood advancements. We'll learn about these in details in the upcoming TBL. But the first childhood advancement is the rubella or measles. And the second one is the scarlet fever caused by Streptococcus pyogenes. The third is the rubella or German measles. And the fourth is the staphylococcal scalded syndrome. And the sixth one is the exanthem sabitum or roseola infantum that is caused by herpes, human herpes virus 6 or 7 serotypes. Okay, so this is why we call it the fifth disease. Now, who is at risk? Of course, children are particularly at risk, particularly those who are in elementary school where there's a lot of mixing between children, so those who are aged 4 to 11 years. Now, in pregnant women, the disease could be very fatal and would have really bad outcomes on the fetus. Okay, it's particularly dangerous also in people with chronic anemia. Okay, so in patients with chronic anemia, we could have really what we call a plastic crisis. So in infections in these people can cause transient reduction of erythropoiesis in the bone marrow, okay, and this results in very severe outcomes. This is due to the temporary cessation of red cell production. But because these people are already anemic, this could result in more severe outcomes. Now, the parents, of course, of children who have the B19 infection could be exposed to this virus and might have infection as well. What's the clinical picture of this of the parvovirus B19 infection? So we have prodromal illness. These are non-specific symptoms. So the first few days would have mild fever, malaise, muscle aches, and headache, and this could be the first 10 days. So this is the infectious period actually. Right? So we have the infectious period where we have the prodromal symptoms. Then 2 to 5 days later, the erythema starts to appear on the cheeks, and this is accompanied by mild arthritis. 1 to 4 days later, a maculopapular rash will appear bilaterally on both sides, and symmetrically on the trunk and the limbs. Okay, now this rash takes around 1 to 2 weeks before it subsides and the patient starts to recover. Okay, so the illness is biphasic. The initial viremia is associated with flu-like illness, and then the later phase is the rash phase that is due to the immune response. Okay. Now the rate of maternal to fetal transmission, vertical transmission, is estimated to be around 33%. Okay, with fetal complications happening in 3% of infected women. So these pregnant women would get the virus infection from their children, for instance, of an infected child in the family, and this could result in fetal complications in around 3% of infected women. So what are these fecal complications? We have the hydrops fetalis. So this is a serious fatal condition that is defined as abnormal accumulation of the fluid in 2 or more fetal compartments, including skin edema and pleural effusion. In some patients, it might also be associated with the polyhydramnios or placental edema. Okay, you can see here also the pallor of the limbs. Okay, here we're seeing the rash on the face, the slap cheek rash, and also we're seeing the lace-like rash on the extremities and a petechial rash on the hands. Here we're looking at the hands of a 17-year-old boy. Okay, so we call it the papillary purpuric gloves and socks syndrome. Okay, it looks like this child is wearing gloves, right? So papillary purpuric gloves and socks syndrome. What about diagnosis and treatment? So here we're looking at the progression of the disease. So you have within 4 to 12 days, you have the viremic phase. During the end of the viremic phase, you have accumulation of IgM, and this persists for several months, around 3 months after recent infection. So an IgG would or IgM could indicate acute or recent infection, but later on IgG develops, and this could indicate previous infection. So this person is immune to the infection. Of course, to detect acute infection, then PCR would be the ideal diagnostic test, and this is used for screening blood in some countries, as virus could be detected in blood for a month. Okay, so this virus could be passed on in blood as well. Treatment, we only treat the symptoms. That means if the patient has fever, we give antipyretic drug. If the patient has pain, we give pain medication and maybe antihistamine to reduce itchiness if there's itchiness with the rash. So I talked about Bocavirus in brief. This disease is supposedly most severe in younger children, but as we discussed, also its etiologic role is still not very clear, and it can be transmitted in respiratory secretions, and there is some suggestion that also can be shed in the stools, okay, because we can find the virus in the stools. So next we will talk about rubella virus, or the German measles disease. So rubella or German measles is also known as the 3-day measles. It's called by the rubella virus. This virus belongs to the Poxoviridae family, genus Rubivirus. This is a positive sense single-stranded enveloped RNA virus, so different from the viruses we've talked about so far today, which were DNA viruses. It has a worldwide spread, and children, of course, are particularly more affected or most susceptible, and to some extent young adults. This is rare in developed countries due to the wide-scale vaccinations, In Lebanon, we have a really good vaccination program. It's in the National Immunization Program, the vaccine for Rubella virus. There was around 11 cases in 2018 in Lebanon. So again, human is the only reservoir for this host. This is why vaccinations are effective, and the virus can be transmitted in the respiratory route. Importantly, also, there is only one antigenic variant of rubella, and the incubation period is around 2 to 3 weeks. So for prevention of rubella, we have a live attenuated vaccine. This vaccine is highly effective. It results in seroconvergence, so production of antibodies that can prevent disease in the majority of vaccinated children or vaccinees, because this vaccine can also be administered to adults if needed, or if they've not been vaccinated, and they result in a very long duration of antibody response and thus protection. The vaccine is administered as part of the MMR vaccine, or the measles, mumps, rubella vaccine, in 2-dose series. The first dose is administered at the age of 12 to 15 months, and then the other dose at 4 years to 6 years of age. Now, the second dose can be administered a little bit earlier than 4 years, but it should be at least spaced 4 weeks away from the first dose. So what about the pathogenesis of the virus? So how does the infection progresses? So remember, we said that this is a respiratory transmittable disease. So the infection starts by inhalation of air droplets containing the virus, and similar to what we talked about in the smallpox, replication ensues in the epithelial cells, and then we have dissemination to the regional lymph nodes, and we have the first viremia. We have here the incubation period. We might have some prodromal symptoms during the incubation period. Then we have secondary replication as the virus is seeded into the skin and other organs, and then the virus can spread to the joints, causing arthritis. Now, the prodromal symptoms are similar to the other viruses that we talked about, the rash-causing viruses. So the virus can cause fever, malaise, lymphoadenopathy, and upper respiratory tract symptoms, and these are called prodromal because they precede the specific symptom, which is the rash. Now, the virus or the person infected with rubella virus can be infectious around 7 days before the rash appears, and then 7 days after the rash. So they have very long infectious period, and particularly the fact that this transmission happens before the rash appears makes it difficult to control its spread, and thus the vaccination remains the key measure for prevention. So symptoms, we just mentioned the prodromal symptoms. Again, malaise, low-grade fever, sore throat, lymphadenopathy, and then the macular rash starts around day 14 to 21, coinciding with replication of the virus in the skin epithelia. And the rash usually starts on the face and extends to the trunk and limbs. And remember, it's called a 3-day measles. Okay, so this is different from the measles, which has longer duration of rash. It's called the German measles or the 3-day measles. Okay, you can see here a baby with this petechial rash. Now, complications, as we mentioned, the virus can spread to the joints and cause arthritis, particularly common in adult females. Encephalitis is rare. The most dangerous complications happen in pregnant women. This is called the congenital rubella syndrome due to maternal viremia, and this can result in severe congenital deformities and can result in abortion. This is why usually pregnant women are asked to do an antibody test for rubella to see if they were exposed. And if not, again, they can get the vaccine, and also they should be careful approaching children who have not been vaccinated to avoid getting the infection. Uh, we mentioned that virus shedding can occur during the prodromal period and last for 1 week after the appearance of rash. In some patients, we can have pink eye associated with it, and also the disease is usually self-limiting, but it's only serious, can be serious in adults, okay, particularly again in pregnant women.